Good afternoon, our dear students. According to schedule, today we have a next lecture for fourth year students, but now it is a lecture for MM groups who have a second semester of fourth year. And now we continue sub-module of hematology, and topic of our today's lecture, it is lymphoma and multiple myeloma. And let's start from the classification. What the classification of lymphoma? Primary, it's very simple. It's divides on Hodgkin's lymphomas and non-Hodgkin's lymphomas. Hodgkin's lymphomas can be divided on B-cell lymphoma that account it for about 85% of diagnosed cases, and within Africa, Burkitt's lymphoma is the most common B-cell tumor. Moreover, it can be not just B-cell, it can be T-cell lymphoma and NK cell lymphomas. Let's discuss more the Hodgkin's lymphomas. First of all, some little historical guideline. Who is Thomas Hodgkins? It is a British physician who was the most prominent pathologist of his time and a pioneer in preventive medicine. In year 1832, Dr. Thomas Hodgkins, working at Guy's Hospital in London, reported a series of 7 cases of enlargement of lymph nodes and spleen, which he speculated might represent a primary disorder of those tissues rather than reactive enlargement. The first descriptions of lymphoid appearance in the affected tissues appeared in late 18th. However, it is not until the seminal observations by Sternberg in year 1898 and Reed in year 1925 that widespread attention is drawn to serious giant cells present in many such cases, which would later come to bear their names and which would soon become regarded as a morphologic hallmarks of Hodgkin's disease. Interestingly, neither Sternberg nor Reed felt this disorder represented a neoplasm. Sternberg believed that it was a variant of tuberculosis, whereas Reed felt to be an independent entity of inflammatory origin. Let's give a definition. Hodgkin's lymphoma, formerly Hodgkin disease, is a potentially curable lymphoma with distinct histology, biologic behavior, and clinical characteristics. And the main points in Hodgkin's lymphoma include: the term Hodgkin's lymphoma described a group lymphomas distinct from the non-Hodgkin's lymphomas. The presumed malignant cells, Reed, Sternberg, and mononuclear Hodgkin's cells compose a minority of tumor cells. Common clinical presentation are palpable lymphadenopathy and constitutional symptoms. Prognosis is largely determined by stage of the disease. Chemotherapy leads to high cure rates even in advanced disease. The late side effects of such treatment, like secondary malignancy, are significant. According to World Health Organization classifications, Hodgkin's lymphoma can be divided in 2 main types: classical Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin's lymphoma. Classic Hodgkin's lymphomas include nodular sclerosis, mixed cellularity, lymphocyte depleted lymphomas, and lymphocyte-rich lymphomas. Etiology. Probable etiology of Hodgkin's lymphoma include Epstein-Barr virus infection and some genetic predisposition, some genetic factors that can provoke, it can be risk for Hodgkin's lymphomas. Pathogenesis include effect of Epstein virus on B cells and formation of malignant cells with the loss of apoptosis and the inflammatory response against these cells. Here you see schematically pathogenesis of Hodgkin's lymphoma from the Medscape. You can evaluate, you can learn it at home and prepare for your practical classes. Clinical presentations of Hodgkin's lymphoma include non-tender lymph nodes enlargement that is usually localized. In 60-80% of cases, it is enlargement of neck and supraclavicular area lymph nodes. Nearly half of patients suffer from mediastinal adenopathy, and nearly 30% other location of lymph nodes enlargement, like an abdominal or extranodal diseases. Systemic symptoms like B symptoms include fever, night sweats, and unexplained weight loss. It is a loss of weight nearly 10% of weight per half of year. Other possible clinical symptoms of Hodgkin's lymphoma may include fatigue, weakness, pruritus, cough, chest pain, shortness of breath, vena cava syndrome, abdominal pain, bowel disturbances, ascites. It can be bone pain. It can be cachexia, anemia, splenomegaly, hepatomegaly, rarely jaundice. It can include such specific symptoms like Epstein fever. It is a rarely seen condition noted in patients with Hodgkin's lymphoma, which patient experience fevers with cyclicity increase then decrease over the average period 1 or 2 weeks. Cyclic fever may also be associated with other conditions, but it is not called Epstein fever unless the fever is associated with Hodgkin's. Symptoms related to lymph nodes enlargements. They refer enlarged, painless, non-tender, superficial lymph nodes. It is specific palpable symptoms that you can't find in patients with Hodgkin's lymphoma. It can be alcohol-induced pain. It's a rare symptom. Patients with Hodgkin's lymphoma complain of severe pain following alcohol ingestion. The pain typically occurs within a few minutes after the ingestion of even small amount of alcohol. Such are interesting and specific symptoms. The mechanism of it is unknown. We still don't understand why it manifests. Symptom related to mass effect of lymph nodes. According to mediastinal mass, it is retrosternal chest pain, it possible cough and shortness of breath. And retroperitoneal lymphadenopathy can manifestate with discomfort and pain in paravertebral or loin regions, particularly in the supine position. Diagnostic workup of Hodgkin's lymphoma include first of all, the gold standard, it is lymph node biopsy. When you find an enlarged lymph node, we should do biopsy and confirmed Hodgkin's lymphoma. Biopsy from another organ with suspected affection. It can be staging and risk stratification. It is obligatory to patient with suspected Hodgkin's lymphoma. It includes medical history and physical examination, X-ray of the chest, contrast-enhanced CT scan of neck, chest, and abdomen. Optimally providing of PET, computer tomography, positron emission tomography. It is full blood count and blood chemistry, and it is screening for HBV, HCV, and HIV screening. Moreover, it have to be pre-screening examination to check for complications and some clinical polyorganic manifestations of Hodgkin's lymphoma. It have to be provided ECG, echocardiography, pulmonary function test, reproductive counseling in younger patients, serum pregnancy patient in younger females. And arbor classification of lymph nodes enlargement in Hodgkin's lymphoma. And you see schematically an example. For example, just neck enlargement. It is stage 1. Neck and chest, especially mediastinal enlargement of lymph nodes. It is stage 2. When it costs three regions and more, for example, neck, axillary, like here, abdominal, and pelvic lymph nodes, it is stage 3. And when it is affected a lot of zone of lymph nodes and affected liver and spleen, it is stage 4. Description of stages of classification. We name this classification Cotswold stage. Stage 1. It is involvement of single lymph node region or lymphoid structure. Stage 2. It is involvement of 2 or more lymph node regions on the sample site of the diaphragm. Stage 3. It is involvement of lymph node regions or structures on both sides of the diaphragm. Stage 3 can be divided on substage 1 and 2. Substage 1, 3-1. It is with or without involvement of splenic, celiac, celiac, or portal nodes. And stage 2, 3-2, it is with involvement of para-aortic, iliac, and mesenteric nodes. And last stage, it is stage 4, with involvement of 1 or more extranodal sites in addition of sites of which designation E has been used. And different designations applicable on any stage of disease. We can divide it from stages A, B, X, E, C, S, and PS. A, it is no symptoms. Stage B, it is clinical fever with temperature more than 38 by Celsius, drenching night sweats, unexplained loss of more than 10% of body weight within the preceding 6 months. Stage X, it is bulky disease, a widening of mediastinum more than 1/3 of the presence, and nodal mass with maximal dimension more than 10 centimeters. Stage E, it is involvement of a single extranodal site that is contiguous or proximal to the known nodal sites. CS, it is clinical stage, and PS, it is pathological stage determined by laparotomy. Just in operation, we can confirm stage PS. And you see here very severe cases of classical Hodgkin's lymphoma. First picture, it is a child. Second picture, it is an adult with a very severe Hodgkin lymphoma. You see how severe enlarged lymph nodes. Okay, diagnosis confirmed by histological classification include determination of Reed-Sternberg cells. They are present just in 5% of cases, and it can be lymphocyte, predominant, tumor B cells. Classic Hodgkin's lymphoma, it is 95% of all cases, can be manifested microscopically by nodular sclerosis. You see it is second picture from the upper. Here you see collagen bands extend from the nodal capsule and encyclical nodules of abnormal tissue. A characteristic lacunar cell variant to Reed-Sternberg cells is often found. The cellular infiltrate may be of the lymphocyte predominant, mixed cellularity of lymphocyte depleted type. Eosinophilia is frequent. Next picture, it is lymphocyte rich. It is scanny red Sternberg cells, multiple small lymphocytes with few eosinophiles and plasma cells, and nodular diffuse type. Mixed cellularity, it is red Sternberg cells are numerous and lymphocyte numbers are intermediate. And last one, it is lymphocyte depleted. There is either a reticular pattern with dominance of red Sternberg cells and sparse number of lymphocytes, or a diffuse fibrosis pattern where the lymph node is replaced by disordered connective tissue containing few lymphocytes. Red Sternberg cells may also be infrequent in this latter subtype. And you see types of cells in Hodgkin's lymphoma. Yes, first picture schematically and lower it is microscopically. It is classic red Sternberg cells. Second picture, it is lacunar cells, and next picture, possible form of red Sternberg, it is popcorn cell. And picture with different cells in classic Hodgkin's lymphoma. Here you see malignant red Sternberg cells. It is binucleate, you see in microscopy, cells with a prominent nucleus. It is derived from B cells at an early stage of differentiation. Nodular sclerosis. It is 70% of all classic Hodgkin's lymphoma. It is most frequent subtype of classic Hodgkin's lymphoma. In most cases, it has at least partially nodular pattern with fibrous band separating the nodules. The disease affects primarily young adults and less often observed in elderly. It is female predominance in 80% of patients with non-classic lymphoma. The mediastinum is involved 50% of patients with it present with bulky disease. Here you see picture of mixed cellularity Hodgkin's disease. Here on the picture it is appearance of unusually diffuse vaguely nodular without bands forming sclerosis. The overall prognosis it also worse in LP or non-classic Hodgkin's lymphoma by varies with stage of disease can be cured in many patients. At low power, the involved tissue appears diffusely effaced by mixed cellular infiltration consisting of scattering diagnostic red cells and varying proportions of major small lymphocytes, large lymphocytes, histiocytes, eosinophils, and plasma cells. Here you see microscopy of lymphocyte-rich lymphoma. Some case of classic Hodgkin's lymphoma with RS cells is classical type of lacunar type, may have a background infiltrate that consists predominantly of lymphocytes, with rare or no eosinophils. Internal lymphocytes with rich classic Hodgkin's lymphoma was proposed. The frequency of each less than 10%. It is more common in young men, usually found in stage 1 and progresses more slowly. The prognosis of this type is very good. Lymphocyte depleted Hodgkin's lymphoma, you see on this slide, it is rarely entirety, accounting less than 1% of all patients with newly diagnosed Hodgkin's lymphoma in Western countries. Histologically, the following two lymphocyte depleted variants were characterized. First, a diffuse fibrosis variant with adjuvant Hodgkin's red Sternberg cells, and reticular variant showing numerous Hodgkin's to red Sternberg cells with bizarre cytologic features. It is comparison of different variant of monoclonal antibodies and red Sternberg cells. Nodular lymphocyte predominant Hodgkin lymphoma. These cells have also been referred to popcorn cells, but World Health Organization recommended to use the term LP cells. A comparison of HRL cells to nucleoli of LP cells are smaller, multiple, and basophilic. Comparison between two types, classic Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. If classic Hodgkin's lymphoma, about 19 out of 20 people with Hodgkin's lymphoma, Ritz-Steinberg cells here are unique to this kind of Hodgkin's lymphoma. And another type, it is only 1 in 10 people with Hodgkin's lymphoma, typically affects age from 30 to 50. It is middle-aged adults, more common in men. So-called popcorn cell is unique to this kind of Hodgkin lymphoma. It is very good prognosis. Over 90% of people go into remission after the excision biopsy and radiotherapy. Nodular lymphocyte predominant Hodgkin lymphoma can relapse later and require another course of treatment, and this can occur after long as 10 years after treatment has finished. In some cases, the relapse takes the form of non-Hodgkin's lymphoma. This process, a lymphoma coming back in different form, is known as transformation. Here you see a macroscopy of 5 centimeters lymph node of patient with in patients with Hodgkin's disease. Here you see example of liver in patient with, you remember, stage 4 of Hodgkin's lymphoma, affected liver. Okay, staging evaluation for Hodgkin's disease. Essential, it is pathologic documentation by hemopathologist. Obligatory for general practitioner, it is physical examination, documentation of B symptoms, laboratory evaluation such as complete blood count, ESR, liver function tests, renal function test, lactate dehydrogenase. Moreover, the workup include chest radiograph, ultrasonography, CT scans of chest, abdomen, and pelvis, and bone marrow aspiration with biopsy. Usually, it's done have to be done bilateral. Essential under certain circumstances, it is performing of liver biopsy if you suspect affection of liver, gallium scan, technetium scan, bone radiographs, MRI, bipedal lymphangiogram, staging laparotomy. Useful but not essential test for Hodgkin's disease, it is self-surface marker phenotypic analysis and gene rearrangement analysis. Here you see example of CT scan of patient with Hodgkin's disease. Here by arrows you see a contrast enhanced computer tomography scan in patient through the mediastinum, shows multiple and large lymph nodes in the perivascular space in the right and left paratracheal region. Nodes in the left paratracheal region cause the trachea to be indented and narrowed on the left side. Note the small bilateral pleural effusion. Here you see X-ray picture of bulky disease with widened of mediastinum. It is CT scans with case of nodular splenic lesions on upper pictures and lower pictures pelvic and inguinal lymphadenopathy in the same patient. Lymphangiography. The result of this test you can see on the picture. It performed by X-ray, usually for patients with Hodgkin's disease, showing the organization of lymph nodes in the pelvis and back of the abdomen. Lymphangiogram is conducted by injecting a radio-opaque liquid due to enter the lymph system through the feet. The fluid travels through the lymph system and remains visible by X-ray. And here you see positron emission tomography that show increased uptake of radiologic positive agent and an enlarged thymus after therapy representative thymic hyperplasia. Factors predicting a poor prognosis in patients with Hodgkin's disease. It is advanced stage as usual, like for all malignancies. It is the most important thing. It is B symptoms, increased tumor bulk, increased sites of disease, advanced age, extranodal disease, poor response to chemotherapy, like for example after 2 cycles, early relapse, elevated erythrocyte sedimentation rate, lymphopenia, and anemia. Okay, and here you see a slide with therapeutic algorithm approaches to the newly diagnosed Hodgkin's lymphoma. Yes, first step, you have a patient with diagnosed Hodgkin's lymphoma. After you determine the stages, is it limited, is it intermediate or advanced, and according to it you can stop this slide for your conspect, and according to the stage it is a different algorithm of further investigations and treatment. Okay, I don't have time to stop. It is a scheme for limited stage, it is a scheme of intermediate stage, and regime of treatment of different agents, and follow-up and treatment during advanced stage. Usual irradiation fields used in Hodgkin's lymphoma. Irradiation here can be mantle, can be para-aortic, you see schematically where is that, inverted Y, and total nodal irradiation of widespread of Hodgkin's lymphoma. Relapse disease treatment. 10 to 30% patients experience relapse. Careful attention should be directed to lymph node sites after the primary treatment, especially if previously involved with the disease are not treated with radiation. New persistent focal symptoms such as bone pain should be investigated with appropriate laboratory and imaging studies. Okay, PET assessment of Hodgkin's lymphoma. We have criteria for assessment Hodgkin's lymphoma according to PET-CT. We name it Dewey criteria 5-point scale. And you see scores from 1 till 5 and additional X score according to PET result. Assessment to treatment response. CR scores 1, 2, 3 together with absence of FDG, avoid bone marrow lesions, and interpreted as complete metabolic response, irrespective of a persistent mass on CT. Next situation, we name it PR. A Dewey score 4 or 5 provided uptake in decreased compared with baseline and absence of structural progression development on CT. CD, also called no metabolic response, a Dewey score 4 or 5 without significant change in FDG uptake from baseline. And PD, it is Dewey score from 4 to 5 with increasing intensity compared with baseline of any internal scan and any of new FDG IVth focus consist with malignant lymphoma. Here you see an examples of PET-CT scans before treatment and after cycles of treatment. Outcomes of Hodgkin's lymphoma. In accessing of long-term 20-year result of treatment, it has been established. First, during the first 5-8 years after the end of treatment, the patient mostly die from Hodgkin's disease progression. After 15-20 years of follow leading cause of death of patients are late complications of treatment. It can be in 10-30% of cases secondary tumors and leukemias. From 7 to 16% it is MI. From 4 till 10% it is infection, and 6-7% it is serious damage in the lung tissue after mediastinal irradiation, particularly when combined with bleomycin. Okay, and this one more picture with presentations of diagnosis. It is CT scans of different patients with Hodgkin's lymphoma. You can work individually with these pictures. Advanced stage of Hodgkin's lymphoma. You see here a clinical example of 32-year-old male patients. You see multiple lymph nodes. He is presented with fever, weight loss. On CT, it is multiple cervical, axillary, abdominal lymph nodes, large mediastinal tumor. It was performed lymphadenectomy and liver and bone marrow involved in this patient. A risk assessment in advanced stage. It is stage of involvement in disease. Risk factor, it is a male. Sex, it is hemoglobin under 8.3. It is low serum albumin, high leukocytosis, and low lymphocytes. And you see regimen and choice of initial therapy in advanced stage, the drugs that can be used for. Okay, targeting of PD-1 in Hodgkin's lymphoma. You see the regimen of this treatment for patient. Here we can use nivolumab and perbrosilumab that acted and can affect patient with Hodgkin's lymphoma. Okay, non-Hodgkin's lymphoma. The term non-Hodgkin's lymphoma encompasses solid tumors or lymphoid tissue which are not Hodgkin's lymphoma. Histological classification of them is very complex. There is great clinical heterogeneity with indolent and aggressive types of disease. Indolent or follicular non-Hodgkin lymphoma often initially responds well to chemotherapy, but cure is elusive. Aggressive or diffuse large B cells non-Hodgkin lymphoma may be cured with conventional chemotherapy combined with rituximab. Analogous stem cell transplant are increasingly used for high risk and relapse disease. It is a main point. Now we discuss it more detailed. Definition. Non-Hodgkin's lymphoma, it is a heterogeneous group of lymphoproliferative malignancies. More than 30 different subtypes of non-Hodgkin's lymphoma had been identified and categorized according to several prognostic factors, including size, growth rate, and anatomic site. Epidemiology. The annual incidence of non-Hodgkin's lymphoma is nearly 5 to 10 new cases per 100,000 persons. Age distribution, it most often middle-aged patients and possible elderly. Male are affected more often than females. Factors that are associated with development of Hodgkin's lymphoma. Most often it is inherited immune disorders such as severe combined immunodeficiency disease, common variable immunodeficiency disease, Viscold-Aldrich syndrome, ataxia telangiectasia, and X-linked lymphoproliferative disorders. It can be a group of acquired immune disorders such as solid organ transplantation, acquired immunodeficiency syndrome, methotrexate therapy for autoimmune disorders, rheumatoid arthritis and SLE, Sjögren's syndrome, and Hashimoto thyroiditis. Different infective agents that associated with development of non-Hodgkin's lymphoma. It is Epstein-Barr virus, the same with Hodgkin's lymphoma. It is human T lymphotropic virus type 1, human herpes virus type 8, hepatitis C virus, and possible connection with non-Hodgkin's lymphoma have Helicobacter pylori, Borrelia, Chlamydia psittaci, and Helicobacter jejuni infections. Moreover, different occupational and environmental exposure can be factors of development of non-Hodgkin's lymphoma. It is a presence of herbicides, organic solvents, hair dyes, ultraviolet light, diet, and smoking. Here you see a scheme of pathophysiology of normal B and T cell differentiation and T and B cell malignancies, usual for non-Hodgkin's lymphomas. Microscopically, it looks like on this slide. You see that they can be indolent and aggressive. It can be small cell and large cell, and it can be nodular or follicular type and diffuse type. And according to it, you see such a different microscopical picture. It can be in non-Hodgkin's lymphomas. World Health Organization classify non-Hodgkin's lymphoma in such way. It can be divided into big groups, B lineage and T lineage. B lineage group include diffuse large B-cell lymphoma with frequency more than 30%. Moreover, often type it is follicular lymphoma, and more rare types like marginal zone B cell lymphoma, chronic lymphocytic leukemia, mantle cell lymphoma, primary mediastinal large B cell lymphoma, and Burkitt's-like lymphoma. Burkitt's and Burkitt's-like lymphoma. T-cell lineage includes, more often it is peripheral T-cell lymphoma, and more rare it is anaplastic large cell lymphoma and lymphoblastic lymphoma. And classification of tumors of hematopoietic and lymphoid tissues according to World Health Organization. I will not read you anything, but you can fix your slide in your conspect to print photo or write in your conspect. It is a classification of all types of non-Hodgkin's lymphomas. Clinical working classification. We can classify by clinical presentation it in low grade, intermediate grade, and high grade. Low grade includes small lymphocytic lymphoma, follicular small cleaved cell, and follicular mixed small cleaved and large cell lymphomas. Intermediate grade includes follicular large cells, diffuse small cleaved cell, diffuse mixed small and large cell, diffuse large cell non-Hodgkin's lymphoma. And high grade can include large cell immunoblastic lymphoma, lymphoblastic lymphoma, and small non-cleaved cell lymphoma, or Burkitt's and non-Burkitt's type. Non-Hodgkin's lymphoma, according to its clinical progression, can be indolent, aggressive, and highly aggressive. Indolent usually can be B-cell like follicular type, SLL and CLL types, marginal zone, and P. And it can be mucosis T cells. It is mucosis fungoids, Sézary syndrome, and primary cut acute lymphomas. Aggressive type, you see, it can be B cells in different type T cells, and highly aggressive, it can be B cells like pre-B lymphoblastic and Burkitt, and T cells, pre-T lymphoblastic. Clinical manifestations of non-Hodgkin's lymphoma. On first place, the same with Hodgkin's, it is lymphadenopathy. Moreover, clinical manifestations can include systemic symptoms like fever, night sweat, the weight loss. It is continuous the same with Hodgkin's. Here, interesting can be neurological symptoms with primary brain lymphoma. It's more typical for non-Hodgkin. It can be bowel obstruction with small bowel lymphomas, immunologic abnormalities, peripheral neuropathies, Poynt's syndrome, and pleural effusion. A diagnosis of non-Hodgkin's lymphomas. Here we should perform the same with Hodgkin's lymph node biopsy. Biopsy of lymph node, it is the main method of diagnosis of lymphoma in general, as Hodgkin's as non-Hodgkin's. Material for morphological study lymph node can be obtained by using aspiration biopsy in suspicion cells. It can be fine needle biopsy for tissue column, open incisional biopsy, a fragment of the lymph nodes, and open excisional biopsy to entire lymph node and conglomerate lymph nodes. For non-Hodgkin's lymphoma, we should perform immunophenotyping. It can be done with immunohistochemistry, immunofluorescence, and flow cytometry. Identification of CD cells or cluster determinates. It can be CD5, it is T cell type, and CD20, it is B cell type. It is microscopic changes. On chest X-ray, you see typical X-ray for different type of non-Hodgkin's lymphoma with enlargement of lymphoid tissues. The same presentations on CT scans. One more scan, it is MRI scan. It is thorax of 55-year-old woman with lower dorsal pain. Here you can note a signal intensity changes of body if D12 there is associated with right-sided large paravertebral soft tissue mass involving the psoas muscle. Biopsy confirms non-Hodgkin's lymphomas. Here you see PET-CT in different regimens with confirming non-Hodgkin's lymphomas. I don't have time to stop on it. Stages of non-Hodgkin's lymphoma. They can be divided on 4 stages. Stage 1, it is involvement of single lymph node region or single extra lymphatic organ or site. Second, stage 2, it is involvement of 2 and more lymph nodes region or same side of the diaphragm, or localized involvement of an extra lymphatic organ or site, more than 1 lymph nodes region that is the same size of the diaphragm. Stage 3, it is involvement of lymph node regions of both sides of diaphragm, which may also be accompanied by localized involvement of an extra lymphatic organ or site, or by the involvement of spleen or both. Stage 4, it is diffuse or disseminated involvement of more than 1 extra lymphatic organ or tissue with or without associated lymph node enlargement. And subtypes can be A and B. A, it when no B symptoms. B, it is when present B symptoms. What we include in term B symptoms? It is unexplained weight loss, more than 10% of body weight in prior 6 months. Unexplained fever with temperature more than 38 or night sweats. Okay, and for prognosis of patients with non-Hodgkin's lymphoma, we can use International Prognostic Index. For all patients, we use scoring low, low intermediate, high intermediate, and high, and a number of risk factors that corresponds to level of risk. A little bit other scoring for age-adjusted index for patient less than 60 years. How much risk factors is correspond to what risk? Okay, microscopic changes. One of the most often cases, it is follicular lymphoma. Follicular lymphoma is classified into the following 3 histological grades. It can be in grade 1, it is from 0 to 5 centroblast and how power filled. You can see on the picture how it looks like. Grade 2, it is from 6 to 15 centroblasts, and grade 3, it is more than 15 centroblasts. Most common of indolent non-Hodgkin's lymphoma is this follicular lymphoma. It's defined as B-type lymphoma of follicle center B cells. Low-grade lymphoma, and it usually affected people older than 60. Etiology of follicular lymphoma. It usually acquired non-random chromosomal translocation. Usually it caused by viruses and chemicals, and it can be provoked by immunodeficiency states. Clinical evaluation of follicular lymphoma. It is slowly progressive adenopathy. Systemic symptoms, spleen and bone marrow are often involved in this type, and it is a primary skin of small intestinal tumor. You see on the pictures a typical clinical presentation of follicular lymphoma. Histology. Here you see pictures with the normal lymph nodes, with cutaneous follicular center cell lymphoma, follicular lymphoma, and diffuse follicular center lymphoma. Okay, next disease, it is Burkitt's lymphoma. It is another type of non-Hodgkin's lymphoma. Here you see the author that was described, was first who described this lymphoma. It is a Dr. Dennis Parson Burkitt. Usually affected, usually it affects African population, and the most epidemiological sites you see like a lymphoma belts. It is a region in Africa that mostly sensitive for Burkitt's lymphoma. And on the picture you see clinical presentation. Usually it affected children. And its specific clinical picture line in geographical distribution I showed you. It is EBV association, and it is different. Is it endemic, sporadic, or HIV associated? And it is according to this type, the different incidence range, age range, tumor site, MYC translocation, and cofactors. The most often it can be endemic. Okay, Burkitt's lymphoma. It is widespread extranodal involvement. It usually manifests with involvement of bones of the jaw, most common in children, especially endemic type, and immunosuppressed individuals, like after HIV infection. Males more sensitive for Burkitt's lymphoma, frequent bulky abdominal disease. It usually manifests with loss of appetite, weight loss, fatigue, night sweat, and unexplained fever. Treatment of Burkitt's lymphoma include therapy should be started as soon as possible because it's very dangerous. It is high-intensity shot regimens, including rituximab. It is analog of stem cell transplantation and radiation therapy. Okay, another type, it is mature T-cell lymphoma or peripheral T-cell lymphomas. It makes up less than 15% of non-Hodgkin's lymphoma. It can be classified on cutaneous T-cell lymphomas, adult T-cell leukemia or lymphoma, extranodal natural killer T-cell lymphoma, and nasal type, angioimmunoblastic T-cell lymphoma, anaplastic large T-cell lymphoma, and peripheral T-cell lymphoma unspecified. And you see photo with a specific clinical picture of anaplastic large T-cell lymphomas. Another clinical manifestations of mature T cells or peripheral T cell lymphomas. And you see microscopic picture of mycosis fungoides, what is typical for this disease. It is nodular non-Hodgkin's lymphoma in patient with AIDS. You see the oral manifestation of it. Treatment approach to this type, it is dictated mainly by histology. Aggressive non-Hodgkin's lymphoma cure is often the goal of the treatment, and for indolent non-Hodgkin's lymphoma, cure is rarely the goal. Usually the goal is controlling of this lymphoma. Management of indolent. Stage 1 and continued stage. It is using radiotherapy alone. For indolent non-continuous stage 2, 3, and 4 of non-Hodgkin's lymphoma, it usually needed rituximab combination with systemic chemotherapy. What is interesting, elderly patient with significant comorbidities needs chlorambucil and cyclophosphamide. For younger patients, it usually a CHOP regimen that includes chlorophosphamide, hydroxydonomycin, vincristine, and prednisone. Or scheme CVP that includes cyclophosphamide, vincristine, and prednisone. Or another regime, it is fludarabine alone or its combination with cyclophosphamide or methoxytrone. Management of aggressive non-Hodgkin's lymphoma. At stage 1 and continued stage 2, when it is non-bulky and lymph nodes less than 10 centimeters, it is combination chemotherapy, usually 3 cycles of CHOP therapy plus involved field radiation therapy. Aggressive non-contiguous stage 2, 3, and 4 of non-Hodgkin's lymphoma, it is using of rituximab with standard dose of CHOP chemotherapy for elderly, more than 60 years patients with diffuse large B-cell lymphoma. Patients at high risk of relapse. For them, it is using analogs and allogenic bone marrow or peripheral stem cell transplantation following chemotherapy. Acute lymphoblastic lymphoma, it using of acute leukobllastic leukemia therapy. Management of aggressive recurrent. Here, the treatment of choice, it is high-dose chemotherapy plus stem cell transplantation. Second-line therapy regimens include ICE, it is isosfamide, carboplatin, and etoposide. DHAP, it is dexamethasone, high-dose cytarabine, and cisplatin. Or APOCH, it is eposide, vincristine, doxorubicin, cyclophosphamide, and prednisone. Management of indolent recurrent non-Hodgkin's lymphoma, including single alkylating agents, novel biological agents, and small molecular inhibitors such as ofatumumab, lenalidomide, and tersirolimuz. Combination therapy, CVP, CHOP, and others. Porine analogs like fludarabine and 2-CDA. It can be used rituximab in standard or extended schedules of administration and radioimmunotherapy. Management of T-cell lymphoma. Treatment options for T-cell lymphoma can be categorized as follows. It is combination of chemotherapy regimen CHOP and CHOP plus etoposide, gemcitabine-based regimens. Single therapy agents, it is pralatrexate. It can be used monoclonal antibodies like alemtuzumab, immunotoxin denoloukin, diftitox, and novel biological agents and small molecule inhibitors like histone deacetylase inhibitors, for example, vorinostat, parabinostat, and others. And responding criteria for non-Hodgkin's lymphoma, it is without extra using PET. It is another methods of investigation, and according to presence of physical examination, what with lymph nodes, lymph node masses, and bone marrow, according to their presentation, we can use a criteria to check in is it present response on treatment or not. And main principles of radiation therapy, you can work with this slide individually. We have such a complication like tumor disease syndrome. For it, presence of the laboratory hallmarks like high potassium, high uric acid, high phosphorus, and low calcium. Symptoms of tumor lysis syndrome, it is nausea and vomiting, shortness of breath, irregular heartbeat, clouding of urine, lethargy, and joint discomfort. High-risk features include histologies of Burkitt lymphoma and lymphoblastic leucoma, occasionally patient with DLBCL and CLL. Spontaneous TLS, elevated white blood cells, bone marrow involvement, pre-existing elevated uric acids, ineffective of allopurinol, and renal disease or renal involvement by tumor. Treatment of tumor lysis syndrome you can see here. One more time, for comparison, Hodgkin's lymphoma, differentiation between them and non-Hodgkin's lymphoma, you can see the typical places of involved contiguous nodes, yes, like neck and mediastinum, for example, for Hodgkin's lymphoma. Here it is more typical, for example, axillary or pelvic. Okay, and one more topic for today. Let's walk with it rapidly. It is multiple myeloma. What is that? It is plasma cell malignancy in which monoclonal plasma cells proliferate in bone marrow, resulting in an overabundance of monoclonal paraprotein or M protein, destruction of bone, and displacement of other hematopoietic cell lines. First, it was described in year 1848. Multiple myeloma was a part of spectrum of disease ranging from monoclonal gammopathy of unknown significance to plasma cell leukemia. Multiple myeloma accounts for 10% of all hematological cancers. Multiple myeloma is a heterogeneous disease with survival ranging from 1 year to more than 10 years. Etiology of it. The precise etiology of multiple myeloma has been established. Roles have been suggested for a variety of factors, including genetic causes, environmental and occupational causes, like radiation, chronic inflammation, and infection. Genetical causes. They have been reported on 2 or more first-degree relative and identical twins, although no evidence suggests a hereditary basis for the disease. Environmental or occupational causes. Case-controlled studies have suggested a significant risk of developing multiple myeloma in individuals with significant occupational exposures in the agriculture, food, and petrochemical industries. An increased risk has been reported in farmers, especially in those who use herbicides or insecticides, in people exposed to benzene and other organic solvents. Smoldering multiple myeloma. It is monoclonal gammopathy of undetermined significance is defined by the presence of 3 criteria. They include serum monoclonal M protein concentration less than 3, bone marrow plasma cell concentration less than 10%, and no evidence of end organ damage. It's usually seen in 2/3 of elderly Caucasian population. Pathophysiology. I will not stop on it, please read at home. Pathophysiology, typical signs and symptoms of multiple myeloma. Presenting signs and symptoms of multiple myeloma include bone pain, pathological fractures, weakness, anemia, infection, often pneumococcal, hypercalcemia, spinal cord compression, and renal failure. It is the most typical symptoms for multiple myeloma. In approximately 30% of cases, multiple myeloma is discovered through routine blood screening when patients are being evaluated for unrelated problems. In 1/3 of patients, multiple myeloma is diagnosed after pathologic fractures occurs, such as fractures commonly involve the axillary skeleton. 2/3 of patients complain of bone pain, commonly with the lower back pain. This bone pain is frequently located in the back, long bones, skull, or pelvis. Bone pain is the most common presenting symptom in multiple myeloma. Most cases series report as 70% of patients have bone pain at presentation. The lumbar spine is one of the most common sites of pain. The symptoms that should alert physician to consider spinal cord compression are back pain, weakness, numbness, or dysesthesia in the extremities. Occasionally, a patient may come a medical attention for bleeding resulting from thrombocytopenia. Rarely, monoclonal protein may absorb clotting factors and lead to bleeding. Confusion, somnolence, bone pain, constipation, nausea, and thirst are presenting symptoms of the hypercalcemia. Abnormal humoral immunity and leukopenia may lead to infection. Pneumococcal organisms are commonly involved. Hyperviscosity may be associated with a number of symptoms, including generalized malaise, infection, fever, paresthesia, sluggish mentation, and sensory loss. Patients may report headaches and somnolence, and they may bruise easily to have hazy vision. Carpal tunnel syndrome is a common complication of myeloma, anemia which may be quite or severe in such patients. On physical examination, the eyes may show exudative detachment, retinal hemorrhage, or cotton wool spots. Ecchymosis or purpura from thrombocytopenia may be evident. Bony tenderness is not uncommon in multiple myeloma, resulting from the focal leading destructive bone lashes or pathological fracture. Pain without tenderness is typical. Pathological fractures may be observed. Neurologic findings may include a sensory level change, like a loss of sensation below a dermatome corresponding to a spinal cord compression. Neuropathy, myopathy, and tinal sign, Fallen sign due to carpal tunnel compression secondary to amyloid disposition. Extramedullary plasmacytomas, which consist of soft tissue masses of plasma cells, are not uncommon. Plasmacytomas have been described at almost every site of the body. On evaluation of abdomen, hepatosplenomegaly can be discovered. Cardiovascular system examination may reveal cardiomegaly secondary to immunoglobulin deposition. Moreover, amyloidosis may develop in some patients with multiple myeloma. The characteristics physical examination findings that suggest amyloidosis include following: shoulder pad sign, macroglycemia, typical skin lashes, post-proctoscopic peripalpebral purpura. The shoulder pad sign can be defined by bilateral swelling of the shoulder joints secondary to amyloid deposition. Diagnosis and workup in all patients should include a history and physical examination, obligatory. To differentiate symptoms and asymptomatic of multiple myeloma, the following baseline laboratory studies are needed. It is CBC with differential and platelet counts. It is examination of peripheral blood smear, blood urea nitrogen, serum creatinine, creatinine clearance and serum electrolytes, liver function tests, serum calcium, albumin, lactate dehydrogenase, and beta-2 microglobulin. And we have criteria for confirming multiple myeloma. It is a mnemonic that includes C, it is calcium elevation, R, it is renal dysfunction, A, it is anemia, and B, it is bone disease. Serum and urine analysis includes quantitative immunoglobulin levels. Assessing changes in levels of various proteins, particularly M proteins, help track disease progression and response to treatment. Urine analysis, it is a part of initial diagnostic workup, includes evaluating 24-hour urine for total protein. Next test, it is free light chain assay. Along with the serum analysis, yields high sensitivity while screening for multiple myeloma and related plasma cell disorders. Next test, it is quantitative immunoglobulin levels. Here we check for levels of immunoglobulin G, A, and M for confirming multiple myeloma. Next test, it is beta 2 microglobulin and C-reactive protein. Moreover, we can use serum viscosity for checking in patient with central nervous system symptoms, nosebleed, or very high M protein levels. Bone marrow evaluation. The percentage of clonal bone marrow plasma cells, usually more than 10%, is a major criteria for diagnosis of multiple myeloma. The percentage of plasma cells in bone marrow estimated in unilateral bone marrow aspiration and biopsy. Immunohistochemistry or flow cytometry can be used to confirm the presence of monoclonal plasma cells to more accurately quantify plasma cells involvement. The cytoplasm of abnormal plasma cells contain either copper or lambda light chains, and predominance of one or other light chains expressing plasma cells indicate clonality. Obtain bone marrow aspirate and biopsy samples from patients with multiple myeloma to calculate the percentage of plasma cells in the aspirate. Here, a reference range is up to 3%, and to look for sheets or clusters of plasma cells and biopsy specimens. Histological findings. Plasma cells are 2-3 times larger than typical lymphocytes. They have eccentric nuclear and smooth in contour with clumped chromatin and have perinuclear hollow or pale zone. Many cytoplasm is basophilic. Many multiple myeloma cells have characteristic but not diagnostic cytoplasmic occlusions, usually containing immunoglobulin. The variants include Mott cells, Russell bodies, grape cells, and Morula cells. Bone marrow examination reveals plasma cell infiltration, often in sheet of clumps. This infiltration is different from the lymphoplasmacytic infiltrations observed in patients with Waldenstrom microglobulin anemia. Cytogenetic studies. Although multiple myeloma may be morphologically similar, several subtypes of disease have been found in cytogenetic studies. Here you can see a description of them. Radiography. Simple X-ray indicates for the evaluation of skeletal lesions, and skeletal survey is performed when myeloma is in differential diagnosis. Plain radiography remains the gold standard imaging procedure for stenting newly diagnosed and relapsed myeloma, according to International Myeloma Working Group Consensus Statement. Perform a complete skeletal series, a diagnosis of multiple myeloma, including skull, long bones, and spine. MRI imaging, it is useful for detecting thoracic and lumbar spine lesions, paraspinal involvement, and early cord compressions. Moreover, we can use for more detailed picture positron emission tomography. The same things and the same enlargements we can see there. Here you see algorithm of imaging. In what case we can use CT scans, in what case MRI scans, or for example PET MRI. Staging. Staging is cumulative evaluation of all diagnostic information gathered useful for stratifying the severity of patient's disease. Currently, 2 staging symptoms of multiple myeloma are in use. First, it is the left part of the slide. It is Salmon-Diury system, which has been widely used since year 1975. And second, in the right, it is International Staging System, developed by International Myeloma Working Group and introduced in year 2005. Both of them are in clinical use. You can fix them for yourself. Approach consideration. Physicians must understand both the natural history of multiple myeloma and possible current therapy and treatment of disease. The objective in therapy is to obtain the deepest response in the first round by choosing the appropriate regimen. This should lead better overall survival in both transplant and non-transplant patients. Although multiple myeloma remains incurable, several drug therapies are available in the treatment of patients with multiple myeloma, as are autologous stem cell transplantation, radiation, and surgical care in certain cases. For primary induction therapy in patients with multiple myeloma who are candidates for transplantation, the guidelines recommend the following combined as preferred regimens. You here see the drugs, the chosen drugs. Other recommended regimens according are as follows. Okay, it is continue of treatment. It is second line treatment of multiple myeloma. What drugs and what additional methods like erythropoietin treatment, corticosteroids, plasmapheresis, and surgical inflammations as adjuvant therapy also may include additionally to main biological and chemotherapy drugs. Moments in combination of chemotherapy and immunotherapy. Okay, moreover, it can be used interferon alpha therapy. These drugs not appear to be effective for inducing remission, and randomized control trials showed that patients do not benefit from the addition to interferon to melphalan and prednisone. Radiation therapy. Multiple myeloma is extremely sensitive to radiation. Physicians use radiation to treat symptomatic lesions and to stabilize both at risk to fracture. Physicians also use radiation to treat spinal cord compression. Low-dose double hemibody irradiation has been studied as a systemic therapy for refractory or relapsed multiple myeloma, but without dramatic success. In the pain is mild if less than 50% of the bone is involved, a course irradiation can be initiated. Radiation treatment can result in additional early bone loss due to inflammation, and weight bearing should be limited for first 4-6 weeks. Therapy for skeletal related events include biphosphonate as specific inhibitors of osteoclastic activity and used to treat bone resorption. Moreover, it can be used denosumab. Adjuvant therapy of complications. The treatment of pathological fractures, physicians should orthopedically stabilize and irradiate these lesions. Patients who may have spinal cord compression need a rapid evaluation, may have a necessity urgent transfer to center equipped with MRI for diagnosis or a center with radiation oncologist for urgent therapy. Patients with spinal cord compression due to multiple myeloma should deny corticosteroid therapy immediately to reduce swelling. Erythropoietin may ameliorate anemia resulting from either myeloma alone or from chemotherapy. Pain management. It had been used for patients with pain syndrome. And it uses anti-myeloma therapy, radiation, or balloon kyphoplasty in specific indications that may control pain in patients. The treating physician should take into account several patient pain, especially back pain, is due to other reasons, not for myeloma itself. It can be administration of paracetamol, other non-steroidal anti-inflammatory drugs, or for example oral tramadol or codeine, or for example it is fentanyl or buprenorphine patches or oxycodone. Okay, that's all for today. I understand that it was quite a difficult lecture. That's why, as usual, I send it on my YouTube channel. You can work with it further with your conspect in preparation to practical classes. And as usual, if you have questions, you can write in the comments under the video and in our Facebook page. And please leave your names and group numbers in the comments under the video. For today, that's all. Thank you for your attention.